topic, the degenerative spinal deformities is one of the most discussable topics in spine surgery, probably. And I asked my dear friend Onur Yaman to make his talk not more than 20 minutes, so then we can discuss it.
Good evening to everyone. First of all, I'd like to thank Professor Dr. Mehmet Sileli for inviting me and let me the first webinar of Middle East Spine Society. And hello to everyone. My topic is management of degenerative spinal deformities. In every presentation that I'm talking about degenerative scoliosis, I'm inserting this first slide. I think this slide summarizes the life. The spine is aging. So this is a slide from the paper of Max Ivy. The degenerative deformity is a complex structure and it affects like a domino effect. The instability causes deformity, the deformity progresses, it causes stenosis, and it causes lots of symptoms. If we talk about the natural history of the lumbar degenerative scoliosis, does the lumbar degenerative scoliosis progresses? Yes, it progresses. What kind of lumbar degenerative scoliosis are progressing? If the curve of the degenerative scoliosis is greater than 30 degrees, and if the vertebral rotation of the apical vertebra is greater than 2, and if the allostasis of the deformity is greater than 6 millimeter, and if the intercrest line is over L5, we know that it will progress. And we have to operate these patients. The literature tells us that we have to operate these patients because if you don't operate these patients, the conservative treatments doesn't give any improvement for the health-related quality of life factors, but surgery does it. So, in which cases do we have to decompress? Again, if the degree of the scoliosis is less than 25 degrees, and if the scoliosis is stable, and if the radiculopathy is the main symptom, we have to, or let's say, we may only decompress the level. And according to the literature, if the scoliosis is greater than 25 degrees, and the back pain is the common symptom, and if the lateral listhesis is greater than 3 millimeter, and during the surgery, if we remove the 50% of the facets, so we have to decompress and also stabilize these patients. Before coming to the main subject, we have to talk about, I think, about the 3D alignment and 3D balance. According to the Dupuy set, the alignment is static and the balance is dynamic. They are different things. So there is a corners of economy term here. If the patient is in the green area or in the blue area, the patient has a good balance. So the patient doesn't need any loss of energy. But if the patient comes to the red area, this patient has an imbalance, is out of the stable area, and is loss of energy. So if a patient has a positive SVA, it means that the health-related quality of life factors decreases in time. And in 2012 and after the 2013, SRS-Schwab classification has been determined. According to this classification tells us that we have to bring the pelvic incidence and lumbar lordosis less than 10 degrees. We have to get the SPA less than 4 centimeter, and we have to bring the pelvic tilt less than 20 degrees. But this classification doesn't tell us how do we have to operate these patients. First of all, to operate a lumbar degenerative scoliosis, we have to get a good scoliosis graph. We have to see the head of the femurs so that we can measure the SPA, we can measure the pelvic incidence, we can measure the pelvic tilt. There are lots of tools to measure that, like SurgiMap, Cheops, OrthoView. Why is the SPA, the pelvic incidence, and pelvic tilt are important? We have to get the patients a good, correct scoliosis graph. We had a patient like this woman that has admitted to our outpatient clinic. The patient was standing, bending forwards. We went a X-ray. The real X-ray was on the left side, but this patient come to us with this X-ray. The left one is the right one. The right one is the corrected one. The radiology technician told her to stand up. How can she do? She was standing up upright. So what does it mean? If a patient has an SPA with 22 centimeters, and if a patient has an SPA with 7.5, it differs all surgeries. So what do the terms pelvic tilt, pelvic incidence, and lumbar lordosis means? And how can we use them in our daily practice? So if you look on the left side, the pelvic incidence is 79 degrees. On the right side, it's 40 degrees. So if you want to operate this patient on the left side, you have to give this patient a different lumbar lordosis. And if you want to operate the patient on the right side, you have to give a lumbar lordosis at least 50 or 55 degrees. So the pelvic incidence determines the lumbar lordosis. We have to give the lordosis according to the pelvic incidence. So SPA is important, but is it enough? No, it's not. We have to know that the pelvic incidence is a compensation mechanism. So there are kinds of patients here. On the left side, this patient has an increased SPA, has a normal pelvic tilt. In the middle part, the patient's SPA and pelvic tilt is normal. On the right side, the patient has a normal SPA but increased pelvic tilt. So we have to know the pelvic tilt values. What does it mean, increased pelvic tilt? It means that this patient is using his compensatory mechanisms. If a patient has a positive sagittal vertical axe, first of all, the pelvis retroverse, then the hip flex, the knee flex, and the patient tries to bring his head over the pelvis. Like this, let's say we don't know anything about SPA, we don't know about pelvic tilts, but we can guess if the patient uses his pelvic tilt or not. As in this case, the SPA is nearly normal. If you look to a normal pelvis, you may see the pelvis in this shape, but for this patient, the pelvis, as you see here, has retroverted. You cannot see the inside of the pelvis here. Again, retroverted pelvis and a normal pelvis. So we can guess the patient, if the patient has a retroverted pelvis, only looking with the anterior posterior view of the pelvis. This is a program known as Cheops. I don't think if it works or not. You see the pelvic tilt on the left side, and if you bring this patient to the green area, you may see that the SPA will increase. Let me check it, if it will work or not. It's not working. So, if we talk about a balanced spine, we have to get the SPA less than 4 centimeters. We have to bring this pelvic tilt less than 20 degrees. and we have to bring this pelvic incidence, the difference between pelvic incidence and lumbar lordosis, 9 or 10 degrees. Again, the SRH-FAP classification, we know now the values of the really good balanced spine, but we don't still know how do we have to operate these patients. And in 2014, Bariano and Lamartina has published a paper. And this paper shows us that how to have to operate lumbar degenerative scoliosis cases. First of all, they have divided the deformities in two groups. In the first group, it's the balanced group, and the other part is the imbalanced group. Let me give you some examples. I'll talk with Bariano and let me to present these cases. The type 1 is the non-apical. In these cases, the symptoms are caused by the non-apical segment here. So if you operate only that segment, and if you decompress and make a selective fusion, the patient will be good after the surgery, like in this case. In type 2, if a patient has a limited area at the apex here, you have to operate the apical level and fuse that segment, like in this case. And if the patient has a pure coronal lumbar degenerative scoliosis, you have to only operate at selective levels. And in type 4, if the patient has a sagittal imbalance, it's type 4A. If the patient has a sagittal and also coronal imbalance, it's type 4B. So you have to correct all the deformity here, like in this case. So one of the other problem is to evaluate the L5 and S1 level. Do we have to fuse that levels or not? There are lots of papers about and to fuse that level, and there are some papers are against to not to fuse that level. We have to know the properties of L5. First of all, the deep localization of L5 is an important criteria. The L5 takeoff is another parameter. If the patient has a previous decompression at L5, S1, and if there is a central or pyramidal stenosis, you have to choose L5, S1 segment. So now we come to the decision-making part. If you need to fix the sacrum, you have to think it twice because the pseudoarthrosis rates are very high, and there are type of fixing the S1 with adding iliac fixation. And one of the most important things are that when we have to stop at L5 or S1, we have to think it about twice. Again, a paper stopping at L5, it's colleagues who are saying that you have to not stop at L5 tells us that they have a high degenerative disc degeneration at the adjacent segment here. So if you stop at L5, you may have really revision problems. And let me show you one of my cases. This patient was 65 years old, has previous lumbar disc surgeries. This patient's main symptom was she was bending forward, has neurogenic claudication. And if you look at the sphenopelvic parameters here, the SPA is not too bad, but if you look at the pelvic tilt here, you may see that it has increased. So this patient is using her compensatory mechanisms to bring her head over the pelvis. So I decided to make an L3 pedicle substruction osteotomy with stabilizing this patient from T6 to iliac. And this is the postoperative views. Now this patient has a good SPA. If you see the pelvic tilt here, now this patient is not using her pelvic compensatory mechanisms now. And we have given this patient a good lumbar lordosis here. Preoperative of the patient, postoperative view of that patient. And if you look here, the difference between pelvic incidence and lumbar lordosis is 45. It means that this patient has not a spinopelvic harmony, but after the surgery, this patient has a good spinopelvic harmony. The difference is now 3 degrees. Now another case that has been operated because of lumbar disc and lumbar degenerative scoliosis. The patient was having a 55 degrees scoliosis here and also a lumbar kyphosis here. A colleague has operated this patient. If you look only the cop angle here, now after the surgery the patient is very good. And if you look at the SRS Schwab classification, we may see that this patient has a good spinopelvic parameters, but something happened at the 6 months follow-up. The proximal screws pulled out and there is a pseudoarthrosis at S1. It happens because the coronal balance has not been determined after the surgery. So I have operated this patient, I've revised the upper screws, I went to the S1 and I went to T3. And these are the post-operative views. Preoperative of the patient's view shows us that the coronal imbalance, but after the surgery, we have now a good coronal balance, and we have a better SPA after the surgery here. Another case that we have operated with dynamic instrumentation here, the patient has a 31 degrees cop angle here, has a 14 centimeters positive sagittal vertical axe. If we look at the difference of pelvic incidence and lumbar lordosis, we may see that this patient has not a good spinopelvic harmony. Then we decided to operate this patient with L4 pedicle substruction osteotomy and diffuse this patient from T10 to iliac. And after the surgery, the patient's SPA is better than the preoperative views, and you may see we have a good lumbar lordosis. And another case, this female is 65 years old and had lumbar disc surgeries before. Now this patient has a neurogenic claudication, and you see that this patient has a 14 centimeters positive sagittal imbalance. The lumbar lordosis is not good, and we have operated this patient from T9 to L5, and we have performed the L3 pedicle substruction osteotomy here. You see that we have a good lumbar lordosis after the surgery, and you may see that the SPA is better than the preoperative view. Before the surgery, the patient has not a good spinopelvic harmony. The difference was 55 degrees, and after the surgery, the patient has a good spinopelvic harmony. So this is my nightmare case. This patient was 53 years old, has back pain and bilateral leg pain, bends forward while walking. These are the preoperative images. Then I performed an L3 pedicle substruction osteotomy because the patient has a greater SPA positive sagittal imbalance. After the surgery, I bring this patient's head over the pelvis. Everything was fine, but something happened. The patient was complaining about right leg pain after the surgery. I have checked the CT and also checked the MRI, but there was no abnormality there. Then I have decompressed the nerve root here. I hope the video will work and I will show the reason there. Then I have operated this patient 4 times more, and at the end of the patient, we had a patient like this. The quality of the bone is very bad. We had a fracture dislocation here now. We have a neurological deficit. You see the dislocation here. We got an infection, and after that, the patient got a deep vein thrombosis and also aphasia. So, lumbar degenerative scoliosis are really very complex surgeries. The complication rates are very high. First of all, we solve the infection problem of the patient. Then we perform the VCR to L3. We insert the cage here. We inserted screws from T9 to L5 and also to iliac links. And this is the postoperative view of that patient. If you look, the preoperative SPA was very bad. The second surgery was good, but it failed. Now this patient has a positive sagittal imbalance still, but this patient could work now and works in his own restaurant here. So nothing has finished yet. If you look at the top of this system, I think we have thought that it will be failed from the proximal junction. But this patient come to us with the rod breakage here. Now I will operate this patient, I think, in next week. So as a conclusion part, we have to think, we have to take care of the containment of the patients. We need a good surgical planning. We have to take the balance, not only the sagittal balance, but also the coronal balance. And we have to know that the complication rate of the lumbar degenerative scoliosis are very high. So the preoperative surgical planning will be very good and will increase our success after the surgery. This is my speech. Thank you so much for listening me. I think there will be some questions.
Thank, thank you, really. Our friends are asking, one question is that, how do you manage the proximal segment instrumentation? Do you use,
Sorry, I couldn't
how
get
do
you.
you manage the proximal segment instrumentation? Do you use GAP score while
GAP,
making the instrumentation decision?
the GAP score has been defined by Ahmet Alana and his friends, and I think it will work. So we have to use that because in many cases, and also in their paper, they have showed that there is really a relationship between the gap score and the proximal segment instrumentation. So we have to use that. And what I'm doing now, I'm using hybrid systems. If I need a fusion at the deformity, I use the fusion, and to protect the proximal junctional segment, I'm using hybrid systems.
With hybrid system, do you mean some dynamic fixation in some levels?
Yeah, I'm using pick rods at the proximal levels. I pass the apex of the scoliosis. I came to the end plate and I passed that part, and I used maybe one or two segments to the proximal levels, and I use their pick rods.
Peak rods is the rods that is possibly flexing, isn't it?
Yes, we have.
Flexing rods.
Yes, we have tasted it at the top university at Ankara. The, let's say, semi-dynamic systems like the pick rods. We
Okay.
have compared it with the titanium rods there, and we showed that the pick rods are really working. It's stabilizing the segment in flexion and also in extension movements and motions.
Okay. Okay. Between us, there is our friend Salman. He is asking, how important is it, the coronal balance? Do you think coronal balance is more important than sagittal balance, or vice versa?
Sorry. First of all, sagittal balance is more important than the coronal balance. the main problem that I'm having trouble with this elderly people to give a good coronal balance, because the lumbar degenerative scoliosis is not like adolescent idiopathic scoliosis. Because in the adolescent idiopathic scoliosis cases, the quality of the bone is very good. So you can move, you can rotate the vertebra, but in these elderly people, the quality of the bone is very bad. So one of the important things to maintain the coronal balance is very difficult in these cases. But according to the literature, the coronal balance is not so important as the sagittal balance. At conclusion, sagittal balance is more important.
Okay. Another question. Do you, from Dr. Selim Ayhan, do you add interbody fusion to the peak growth levels?
Selim Ayhan is asking good questions. No,
Yeah.
the question is no.
Do you add interbody fusion to the levels that you have placed peak growth?
No. The answer is I'm not inserting any interbody fusion at the peak group, because the idea of the dynamic semi-rigid systems is not to fuse that level.
Okay. Okay. Another question from our friend Dr. Jose Antonio Matthew. Would you recommend never to stop instrumentation at L5 in degenerative scoliosis?
This is
Never to
again,
stop at L5.
no,
You always go downward.
no.
Do you?
If I, as I showed at the beginning of my presentation, there are some criteria there. If the patient has operated at the L5 S1 segment, if there is a lateral recess there, if there is a spinal stenosis there, if the L5 takeoff is greater than 15 degrees, if the L5 is, the intercrest line passes over the L5, you have to go to S1. But the disadvantage of going to S1 is the high pseudoarthrosis rate. So going to S1 or not is still discussing.
Yeah. Okay. One more question from Salman. What is the latest recommendation for iliac screws? I think he means the how to place it, the iliac screws. And what are the indications of iliac screws?
There are some biomechanical papers. They say that if you use S1 screws with interbody cage, and if you use the S1 plus iliac screws, they are nearly same strongly as biomechanically. But the fusion rates are higher in the L1 S1 interbody cages group. So some of our colleagues say that you have to keep the iliac screws as a rescue surgery. You may have some problems during the surgery, so try not to insert the iliac screws at the beginning. Keep it into the second surgeries. What I'm doing, especially in the L5 S1 segments, inserting iliac screws are very easy, and if you insert iliac screws, it will decrease the surgery time and bleeding. If you take a care to the L5 S1 interbody cages.
Okay. I want to know, actually, saw that you are measuring with the whole spine films, placing the measurements on the levels. Which program do you use there?
I'm using SurgiMap.
Surgery map.
Yes, you can, and my colleagues can download it on the Google. It's free, and new systems are coming like Cheops AutoView, but some of them you have to pay for it. And I think in the future, everyone has to, let's say, I think will be very good if they use these programs, because before starting the surgery, you're planning your surgery very good. Nearly after the surgery, you get the values that you have measured before the surgery.
Okay. This is my question to you. Actually, you sometimes prefer to perform an osteotomy. What are the indications of osteotomy instead of interbody fusion?
In some cases, if the SPA is too high, you cannot bring that patient back, the head over the pelvis. So in some cases, you may need especially multiple ponte-osteotomies or single pedicle substruction osteotomies. But performing these osteotomies, especially pedicle substruction osteotomies, to the elderly patients, it's bleeding too much, and it will increase the complication rates and also increase the infection rates. So I prefer in most of the cases osteotomies to maintain the sagittal balance.
Yes. For sagittal balance, osteotomy is better than any probably, huh? Yeah. Uh, One more question from Salman. Where do you use bracing when trying conservative treatment? Actually, before doing before implementation of a surgery, do you use any bracing?
First of all, I try it for maybe 8 or 12 weeks, but as I showed at the beginning of my presentation, the conservative treatment will not provide the patient's health-related or quality life factors. If you operate a patient, it will be the patients have a benefit after the surgery. Not the conservative treatment doesn't give anything to patient, but I'll try because the patients are elderly patients. They have comorbidities. I'll try facet injections. I'll try to send the patient to the physiotherapy. I use bracing, but in most of the cases it doesn't work.
Okay. Another question is about a patient with degenerative deformity and radiculopathy. Do you perform surgeries for radiculopathy only in case of degenerative deformity? And is there an algorithm for that?
Selim Ayhan is really asking good questions. I think
Yeah.
nobody can answer these questions. Like the time is important here. Sometimes we have patients coming to the outpatient clinic. The patient is telling that I'm walking, I could do everything what I want, but for the last 1 month I could not walk. It means this patient has a radiculopathy, and if you only decompress that nerve, even the patient has a sagittal imbalance. If you operate these patients like L3, L4, L4, 5 discectomy, the patients get very good after the surgery. The sagittal imbalance also, you can correct the sagittal imbalance after the surgery. But if a patient has the problems, the symptoms for a long time, you have to uh, decompress and also fuse that levels. As I
That you
told
mean
you
a
about,
short fixation, do you?
yes, if the patient doesn't have a sagittal imbalance, if the patient is type 1, type 2, or type 3, according to Beryano-Lamartine classification, you can only decompress and use short instrumentation. But if the patient has a coronal or plus coronal and sagittal imbalance, you have to correct that deformity. So
Okay.
there is no one answer for Selim Arhan's questions.
Yeah. Um, Actually, I believe also in some instances we can ask the patient that we can perform a very short fixation and a decompression only, but your kyphosis or flat back will not be diminished. And if they accept it, it may be an option. But they may need in the future something for deformity surgery. Yes. What do you
What I'm
think?
doing now, what am I doing now is like what you're doing. First of all, I'll talk about the complications phase. I'll tell the patients the complication of lumbar degenerative scoliosis is sometimes 40 or 60%. So I think you don't need any correction. I may correct your deformity, but it will cause very high complications. So only decompressing or making on the short fusion will be good for you. But sometimes elderly people who are very active tell me that tells me that I want to be stand straight. I want to walk correctly. So in that patients, I tell them, so if you want to do this surgery, I can do it.
Yeah. I think the questions uh, have finished. Do you have any other message about the deformity surgery in the elderly? So then we can finish the session.
First of all, these patients have comorbidities. We have to make as minimum surgery as we can, but we have to talk very good before the surgery because these patients have osteoporosis, this patient has diabetes, this patient has cardiac defects. So we have to talk with the patient and also with the uh, patient's daughter or son about the complication rates, and we have to do the surgeries as minimum as we can because uh, if you will need a revision surgery after the spinal degenerative scoliosis, the complication rate of the revision surgeries will increase in the following surgeries. The success of the surgeries of lumbar degenerative scoliosis is a good surgical planning.
Yes. Yes, we must take care of the sagittal and coronal balance, and we must take care about the osteoporosis of the patients. Thank you. I thank Dr. Onur Yaman for giving the opportunity to discuss the degenerative scoliosis, the problems of surgeries of degenerative scoliosis. I will finish the session here, and I will invite you to our future webinars of Middle East Spine Society. Thank you, Onur, for giving the opportunity.
And I would like to thank to you to give me the opportunity to give the first webinar of Middle East Spine Society. And I will also thank to you really because Mehmet Silali has been operated today because of his eye in the early morning. Now he is in front of the
Yeah,
computer
thank you.
operating.
I have an eye surgery today. Thank you. Wish to see you again. Goodbye. Goodbye, everyone.
See you.